Broadcast is now starting. All attendees are in listen-only mode.
Welcome. My name is Andrew Jones, and I'm the Vice President of North American Sales for LKC Technologies. Thank you for joining us tonight for why and how I adopted handheld ERG testing with the RETeval device into my practice, and that's going to be presented by Dr. Justin Schweitzer. Before I introduce Dr. Schweitzer, I'd like to cover one housekeeping item. For tonight's webinar, we will be using the question functionality of GoToWebinar. So to ask a question, just open up the control panel, open up the question box, type in your question and hit send. And Dr. Schweitzer will stop several times during his presentation to check with me to see if there are any questions. So Dr. Schweitzer specializes in advanced glaucoma, refractive surgical clinical care, and anterior segment pathology at Advanced Thompson Vision. He received his professional training and Doctor of Optometry degree from Pacific University College of Optometry in Forest Grove, Oregon. In 2012, he pursued his dream to focus on glaucoma, advanced anterior segment surgery care, and pathology, joining Advanced Thompson Vision in Sioux Falls, South Dakota. He earned his fellowship in the American Academy of Optometry in 2013, is the optometric externship director at Advanced Thompson Vision, and adjunct clinical professor of the Illinois College of Optometry and Kentucky College of Optometry. Dr. Schweitzer regularly lectures on glaucoma, anterior segment pathology, refractive surgery, surgical clinical care, and surgical management at state, regional, and national meetings. He is currently the chief medical editor for Modern Optometry and has contributed book chapters, journal articles, and case studies in many peer-reviewed and non-peer-reviewed journals. He has research interests in minimally invasive glaucoma surgery and the biomechanical properties of the cornea as it relates to glaucoma. Dr. Schweitzer is an advocate of integrated eye care delivery model and is currently serving as a board member for the South Dakota Optometric Society. He also serves as a board member of the Optometric Glaucoma Society, a member of the American Optometric Association, Optometric Cornea, Cataract and Refractive Surgery, Scleral Legs Education Society, Intrepid Eye Society, and is actively involved in his community's eye care initiatives. So thank you very much, Dr. Schweitzer, for joining us tonight. Please go ahead and take it away.
Andy, thanks so much for the way too nice introduction. I really appreciate it and excited to be here. I just want to thank everyone for taking time away from their family, friends, significant others to come and spend it with me. I know it's never easy after a long day in clinic. You've been seeing patients, you've been grinding away and probably seeing some tough stuff to come and, sit through a 50-minute to hour lecture. But I do truly appreciate it because it makes it fun to be able to do these things when we have colleagues that show up to enjoy and are passionate about things to make our patients' lives better. So I sincerely appreciate everyone taking the time to be here. These are just some disclosures. And really just a few of these will come into play when we kind of get into the case studies. I'll comment on a few different things. So obviously I want to go ahead and disclose everything here as we get into talking about what we're going to be talking about tonight. And this kind of tips off what we're talking about tonight, right? We're going to be talking about a technology that I do think can be very helpful. And I do believe, and I've used it a lot to help me piece together a puzzle for patients. Specifically for me, it's glaucoma. I utilize it a lot in my glaucoma clinic. The majority of patients that I see is glaucoma, but it also serves a really nice purpose in helping to manage your diabetic patients. And I'm going to get into that a little bit as we go. It's a handheld device. I'll talk on that a little bit. And just a little bit about my practice. So I'm in a tertiary care practice. All the patients that come in to see me are really referred in. And typically they're referred in for second opinions on glaucoma, or they need to be prepared for glaucoma surgery, sometimes anterior segment disease. And we utilize a lot of technology in our practice. And I like to think of glaucoma like a puzzle. There's a lot of different pieces out there that we use to kind of get to the diagnosis of glaucoma or make us more confident in the diagnosis of glaucoma. And you're going to see here tonight when we get into some of the cases that really using the RETeval and using ERG can help us feel more confident in our diagnoses, or if nothing else, make us feel like, hey, I could wait to bring this patient back at a year, or I can bring them back at 6 months, or I need to bring them back sooner because there's added risk here. And so taking all those different technological puzzle pieces, putting them together to get to that diagnosis or assess risk. And then, of course, we have treatment options, a lot of those on the other side of that puzzle that we piece together as well to get to that puzzle piece of glaucoma. But We're going to also talk about diabetic cases here tonight, where this also can be very, very helpful and useful in that particular patient population. This really should not surprise anyone. I'm a big believer and an advocate that optometry should be heavily involved in the medical eye care model. When you look at these stats here, you can see that optometry is still on the rise, about 13% from the year 2015 to the year 2025. You look ophthalmology, not necessarily stagnant, not declining, but only increasing by about 2.1%. Well, with that, we know that ocular disease is on the incline. It's getting worse, and so we need more eye care providers to manage medical eye conditions. And that could be diabetes, that can be glaucoma. If you look at some of the glaucoma stats right now, over 3 million Americans right now with glaucoma. By the year 2040, there's going to be about 4 million, and by the year 2060, we're going to be at around 6 million Americans with glaucoma. And so having technology that we can utilize is helpful, but also having eye care providers, optometry, taking the reins to manage a lot of these different conditions, whether it's diabetes, whether it's glaucoma, is very, very necessary. There's an imbalance right now. There's more ocular disease than there are eye care providers. And so it's going to be so important that we continue to educate ourselves on the disease processes of the eye so that we can manage these patients and make sure that their lives are fulfilled with good vision going forward. So tonight we're really going to focus on ERG. And when we look at ERG, right, what we're going to talk about tonight is not this type of ERG. This ERG we're going to talk about tonight has a small footprint. It's handheld. It's not your grandparents' ERG. And this is a great illustration of what we're not going to be looking at tonight. When we think of ERG technology, at times we think it could be larger, it's bigger, it could take up some space, but you're going to see tonight when we look at this particular technology that it really takes up almost no space, a really tiny footprint, but a powerful device that really can give us a lot of information and can help us assess risk for not only our patients with glaucoma, but also our patients with diabetes as well. So the definition of electroretinography, I think most of you are familiar with this, but we'll do a quick review of this. Really, it's measuring an electrical response of various types of cells in the retina. So we're going to be looking at the photoreceptors, the rods and cones. We're going to be looking at that inner retinal layers, the bipolar cells. And then we're going to get to those layers that are affected by glaucoma, the ganglion cell layers, and the response to a stimulus. And you can see the RETeval device there being used on a patient, the sensor strips, which we'll talk about here in a little bit as well. So we'll dive more into what this is actually measuring here in a few minutes. So when we think about the ERG waveform, I'll kind of take you through this, and we're not going to dive really deep into this, but I think it's important to understand this because when we start looking at different printouts of this particular ERG, the RETeval from LKC, we want to make sure we understand, well, what parts are we looking for in patients that have glaucoma? What parts are we looking for in patients that have diabetes? And so when we think of what's happening here, there's a light stimulus that comes into the eye. This is an image, this is light, this is what we're utilizing on a day-to-day basis, what our eyes are looking at. The stimulus comes in, it hits the retina. As it goes through the layers of the retina, the first wave you're going to see here is the A wave, and this is looking at photoreceptor function. This is primarily driven by the cones. The bipolar cells are off at this point, and then what happens is you get the B wave, and it inverts the signal from the photoreceptors and transmits it to these inner retinal layers. We talked about those earlier. This would be the bipolar layer. And then finally, the last piece of this is the photopic near response, or negative response, excuse me, the photopic negative response, which is the innermost layers, the retinal ganglion cells. And in that situation, that's where we're going to really care about glaucoma. And then that's going down the optic nerve and, of course, to the brain. And that's really how this function works. And so this really, this waveform that you're seeing here, you're going to see it a bunch as I get into the different cases. You're going to see it in a little bit when we talk about a couple different things. We're going to talk about implicit times, which is speed. That's an indication of cellular stress. We're going to talk about the amplitude, which is an indication of cellular damage. And so keep those two things in mind as we kind of get into the details and more in depth about what we're looking at with this ERG waveform. But first, let me introduce you to the instrument that actually gets us this measurement, that gets us that particular waveform, and that's the RETeval. That's what we're going to be talking about tonight. Really, in all the cases that we look at tonight, that's what was utilized to gain the access, to gain the data that we needed. So this is a full ERG suite. It's in one device, and look at how small it is. And I will stop here and pause and give you some of my experience with it. For me, I'm not personally doing this, but guess who is doing it? My technicians. And we've utilized other ERG technology, and this by far at this point in time is the one that's been accepted most widely in my practice by my technicians. And when we adopt technology in our practice, I may love it, but if my technicians don't love it, then it's not going to really get utilized. And so this has been a really nice additive to our practice because my technicians don't have to move patients around. Patients stay in their exam chair at all times. My technicians are able to go grab this. They're able to take it to the exam room. They have the sensor strips near it. We grab those, and they go in and they do the test in a few minutes. They're able to upload onto my EHR the printout, and I'm able to analyze it, move forward, and educate the patient on this. And so it's so nice because it integrates so well into our workflow. I have happy technicians. And as you're going to see here in a little bit when I get into a few of the cases, and I see a lot of cataract patients because we're in an anterior segment practice. I work with a surgeon that does a ton of cataract surgery. This really isn't impacted by dense medial opacities. And so if I suspect a patient that, I need some additional data, could they possibly have glaucoma because I don't have an accurate OCT or I can't get an accurate visual field because of a dense cataract? This is a nice tool that I'm able to at least gather some information on and assess some risk for that particular patient moving forward with their cataract surgery and then beyond. So a very handy tool. Again, I mentioned it's really not if I love the technology, it's what my technicians say, and really I've loved it as well. It's been a nice addition to managing my glaucoma patients specifically in my practice. This is what it looks like. So you have the docking station there. You actually have the RETeval device, the eye cup, and then really the sensor strips as well. Obviously, those are needed as well. You can see here in this particular image, and you'll get alignment. You want to have it aligned right with the edge of the pupil. And I believe you can see my cursor here, but that's kind of the alignment of the sensor strip. You'll educate and teach your technicians how to do that. And then really to utilize it is very simple. You keep the pupil inside that green circle, and you're going to get a measurement. And so that's the real beauty of this. It's not hard to use. It's easy to train on, and you really get some useful data very quickly from this particular device. So getting into kind of the fun stuff. So when we're talking about this particular device, the RETeval, what are we utilizing it for? Well, really two ocular disease states are what I think of. I think of glaucoma being one, and I think of diabetic retinopathy being the other. And that doesn't mean we're not going to still utilize our OCT. We're not going to still utilize the visual field. We're going to still utilize those things. You're still going to utilize fundus photos. You're still going to utilize your eyes when you're doing a dilated exam and taking a look around at the retina. With diabetic retinopathy, you're still going to utilize OCT angiography. You're still going to utilize photos and OCT. But really, I talked about it earlier. For me, when I think of glaucoma, because that's the main thing that I'm utilizing this for in my particular practice, I think of it like a puzzle. I utilize things like the OCT, the visual field, corneal thickness with pachymetry. I use corneal hysteresis. I piece all those things together to get to that diagnosis or assess risk. I now have implemented using ERG as well, because I could take all those different risk profile from all these different machines and different devices and really build a story and educate my patients on where their risk is. Or if they already have glaucoma, we could talk about how aggressive do we need to be with therapy. The same thing happens with diabetic retinopathy. You're going to see in a little bit here that you can get a value from this particular ERG, from the RETeval, that lets you know what the risk of a patient is to need intervention with diabetes or diabetic retinopathy. It's kind of like patients that smoke. A patient that smokes has an 8-time increase of developing lung cancer in their life. Does that mean they're all going to develop lung cancer? No. But it helps to assess risk, and that's really the beauty of this. And hopefully when I finish up with the cases and we get towards the end here, you'll say, yeah, it's a piece of the puzzle. It's something that can definitely be implemented in my practice. Doesn't mean it's going to be the only thing I do. You're still going to utilize all these other technologies on the slide, but you utilize it in a way to help assess risk and help you make better decisions, and you're more confident in those decisions for your patients. So we think of the different technologies that we're utilizing. We think of visual acuity. We have to check visual acuity in all our patients, but really visual acuity is just testing a very small portion of the fovea. When we think of a 24-2 or a pattern ERG, it's testing about 24 degrees of the retina. We're only getting a small area of the retina. Still can be useful, but when we think of a full field ERG, which is what we're talking about here with this particular technology, we're measuring about 120 degrees of the retina. So we're getting a ton of information in a wide area of the retina to provide us with information. So ERGs, let's stop and let's pause and talk about diabetic retinopathy first. Okay? This is not new information. This has been around for a long time. There's been information published since 1987, and there's 13 publications out there right now using the RETeval device. And I talked about it earlier. Really what we're looking at when we're looking at an ERG printout is we're looking at implicit time or speed, and we're looking at amplitude. The slower, meaning there's more damage, and when we're looking at amplitude, the lower the amplitude, the more damage there is as well. So I'm going to back up. I said that wrong. So implicit time or speed means that there's stress to the cells, so no damage. So implicit or speed is stress, or amplitude is damage to the cells. And so you can see here, just kind of laid out in front of you, what it looks like with someone with no diabetic retinopathy, all the way to the end of proliferative diabetic retinopathy. And you can see that that implicit time has slowed down, and you can see the amplitude has dropped as well. And so we'll get into some cases here a little bit that's going to make this a lot more clear for you as well. So to me, this is really the beauty of the device, because it spits out this number, and I'll go into that in a second. That really is all you need to know if you could get an accurate measurement. The diabetic retinopathy assessment protocol that this spits out uses really 4 different components. You have implicit time, you have amplitude, you have a pupillary response, and you have the age. Those are really the 4 components that it uses for this assessment. Now, this is a clinically validated measurement. There's been plenty of studies done on this. You can see it listed here, cross-sectional and longitudinal. And the number you have to remember as we get into the cases here and we move forward is 23.4. I talked earlier about patients that smoke. Now, when you look at the data on smoking, patients that are smokers have an 8 times increased risk of developing lung cancer in their life. Does that mean every patient that smokes is going to get lung cancer? No, but they're at a higher risk for it. When you look at this diabetic retinopathy score, this DR score, if you measure a diabetic patient with this, patient that has early diabetic retinopathy, patients that you're maybe using this as a screening tool for that have diabetes, if that number is 23.4 or it's greater than 23.4, your patients are at an 11-time increased risk of needing intervention at some point in the next 3 years. So that's the number you want to think of, 23.4. If it's above that, 11 times increased risk of needing ocular intervention within 3 years. And so I think of it a lot like smoking. Does that mean that if they have a score of 28, that they're for sure going to need ocular intervention due to diabetes? No, it doesn't mean that. But what it might mean is that you're going to bring that patient back a little bit sooner and check them out. You may say, hey, I've been evaluating this patient on a yearly basis, but because that number is elevated, because that number is above 23.4, I'm going to go ahead and bring them back a little bit more often. I may bring them back at 6 months. I may evaluate the retina a little bit closer. I may get another test on them. Maybe I'm doing OCT angiography. I'm doing something else on them. I'm going to look a little bit closer for things. And so really, again, it's assessing risk. It allows you to educate your patients better at a higher profile, at a higher level. So I've alluded to this a few times, and I did that on purpose because I didn't want to just say it once and move on. And now we're going to look at it again with interpretation. And the 2 values are the 2 things we really care about are implicit time and amplitude when we're reading these waveforms of the ERG printout. So too slow indicates there's cellular stress. And so when we're talking about glaucoma, we're thinking about the retinal ganglion cell layer that indicates stress to that particular layer. When we're thinking about diabetes, we're talking to the bipolar cells. We're talking about those interretinal layer cells. So we're looking at implicit time, that's stress, too slow. When we think about amplitudes, that's indicative of cell damage. So a lot of times with an amplitude, specifically, let's talk about a glaucoma patient, you may already have damage to the OCT, and that's not going to be surprising to you that you have a reduced amplitude. But what you may find out when you're looking at a glaucoma patient is that their implicit time is slow too. Those cells haven't been damaged yet, but you got to be worried that those cells could become damaged because that implicit time is slow. So even in a glaucoma patient that already has been diagnosed with glaucoma, these measurements using the ERG can be very helpful in managing your particular patients. So keep in mind as we get into the cases here, which is really the fun part of the presentation, implicit time indicates cellular stress, slow is stress, amplitude indicates cellular damage. So let's go through a few printouts. So this would be a diabetic retinopathy assessment normal. And I mentioned it earlier, you can see right up here, the DR score measuring 14.8. Remember that magic number of 23.4. Anything above that, that is increased risk for needing ocular intervention due to diabetes. And here we have a 14.8. We feel pretty good about it. If you really want to get into the numbers and look down here, it's really green across the board. This is measuring implicit time right here. This is measuring amplitude in the right eye, implicit time in the left eye, amplitude in the right eye. For me, when I look at this, I'm looking right at that DR score. I see that number. I can educate my patient on that, and I feel comfortable with it. When we look at an abnormal score here, now we have 24.8. Is it way above 23.4? No, but it's above that, and based on their clinical trials, that means that there's an 11 times increased risk of that patient needing ocular intervention within 3 years. And so does that mean you're going to intervene immediately here? No, but you're probably going to watch this patient a lot closer than you would a patient that has a DR assessment like this. And so when we look at this, what's going on here? Well, you can see implicit time is really slow, up around 100%. It flags it as red. Same thing in the left eye. And so that's contributing to this outside normal limits, it's contributing to that DR score. So let's shift to glaucoma. And really for me, this is probably, my passion. I love glaucoma. I deal with it on a daily basis. It's something that, I've been heavily involved with since I started at Vance Thompson Vision. And we know that the retinal ganglion cell layer matters in glaucoma now. It matters more than ever. We know from a lot of different studies that glaucoma will attack the retinal ganglion cell layer sometimes earlier than it will even attack different parts of the retinal nerve fiber layer. And so we have to pay attention to the retinal ganglion cell layer. We know that a lot of OCTs right now will measure different layers. It'll measure the retinal ganglion cell complex. It can measure just the retinal ganglion cell layer, the interplexiform layer. And these things matter in glaucoma. When you think of every major OCT out there, whether it be an OptiView, whether it be a Cirrus, whether it be a Spectralis, they all have a way to measure the retinal ganglion cell layer. And there is growing data and growing body of evidence that if we can catch things early, and ERG will help us with that, and we can lower intraocular pressure, we can manage these patients, we are able to sustain retinal ganglion cell function. And for me, the big story is assessing risk. That's the big story for me with ERG. I want to assess risk of my patients. If it's a patient that has stress to the retinal ganglion cell layer, then I'm going to talk to that patient about follow-ups. Or, for example, I had a patient today. She came in. We had done SLT on her 6 weeks ago, 8 weeks ago or so. Her pressure at that time was at Tmax, highest pressure of about 28. Today, when I saw her, her pressure was down around 23. Okay, her OCT, or retinal nerve fiber layer, looks beautiful. There's no problems with it. Average retinal nerve fiber layer thickness looks really good, right around 85 or so. She's got no visual field defect, but she's had this fluctuating intraocular pressure varying between kind of 25 to 28. She's had a strong family history. She's got really thin cornea. She had a low corneal hysteresis. So she had a ton of risk going on. Today, we decided to go ahead and run an ERG on her just to see, hey, do we need to get the pressure lower? Are we concerned about anything? Went ahead and did that. She had implicit times that were flagged as red, 100%, just like what you saw in that last case example. And with that being there, that made me a little bit nervous. The amplitudes were normal. We had no trouble there, but that means her retinal ganglion cells are under stress. Did I intervene with anything today? No, we didn't do any new treatment. We didn't start anything, but what I did tell her is, hey, I'd like to see you back in 3 months. I want to check your pressures again. I want to watch this really closely. I'll probably get another OCT in 6 months, and I'll probably get another ERG in 6 months as well. I'm not interested in putting drops on her at this point in time, again, because we got a decent drop in intraocular pressure, but there's that concern because of that slow implicit time that those cells are under stress, and I want to now catch it before significant damage occurs. And so that's where it can be really useful. And you'll see some other cases here in a little bit. This is just a study looking at full field photopic negative response amplitudes, providing the potential reversible measure of interretinal function after IOP lowering. So again, looking at the ganglion cell layer, looking at an interplexiform layer. In patients, if you lower their intraocular pressure, can you protect them from having damage that is not reversible? And so again, for me, the take home is ERG helps me assess risk. It helps me make better decisions for my patients, specifically with glaucoma. So let's look at a couple printouts here. So this would be a normal one. So you can see the printout's a little bit different. In glaucoma, what do we care about? We care about where those red arrows are. Remember earlier I talked about the photopic negative response. It's assessing the ganglion cell layer, the retinal ganglion cell layer. That's what we care about in glaucoma. And so this is the printout that we'll utilize, or that we'll put into the machine of what we want when we're testing these particular patients. And when we look at this, down here is your implicit time. You have your amplitude, and then you have something called the W ratio. And I like to see this W ratio 1 or above, or at least close to 1. And that's looking at the signal through the photoreceptors to the ganglion cell layer. So we have that speed, which is implicit. We have the amplitude, again, implicit time meaning cellular stress, amplitude equaling cellular damage, and then this looking at a bunch of the layers and giving us another nice value to look at. Remember, from photoreceptor up to the ganglion cell layer. When we look at an abnormal one, what do you see here in this particular patient? Again, we're looking at the photopic negative response. What we're seeing here is an implicit time that's falling within normal, but it's borderline. And I like to talk a little bit about green disease here. When we think about green disease with OCT, we hear that all the time. You know, we have an OCT that's thinning right in front of our face, the retinal nerve fiber layer is declining, or the ganglion cell layer is declining, but everything's still staying within normal limits. That can be a patient that has progressive glaucoma. We can't miss that. You look at this particular measurement in the right eye and you see that this is up around 90%. It's still being flagged as within normal limit, but that flag still makes me a little bit nervous because it's really getting close to being into that abnormal, or we need to watch this patient closely. I love it if this number's down at 50% or 2%. Then I'm not as worried. So I'm still thinking about it here. But this particular patient showing damage, the amplitude, you know, definitely red here as abnormal. And then the W ratio down at 0.66, so below that 1.0. We look at the left eye. Implicit time is great, down at 34%. So no stress. Amplitude, really good. And then we look at the W ratio above 1. So this would be a patient, we don't know the rest of the history here, that if they have glaucoma, or if we think they're ocular hypertensive or glaucoma suspect, I'm a lot more nervous about that right eye than I am about that particular left eye. So I'm going to pause there before we get into the cases. We are exactly at about 7:30, which is perfect. I can take a few questions and then we can really dive into some of the cases, which I think is the fun part, because we can apply this clinically to our patient care. Any questions, Andy?
So Justin, just a couple of questions. There was one question about the reports. In the reports, there seems to be a picture of both eyes in the report. They were just wondering what you use those pictures for.
Yeah, great question. So a lot of times what I do is, I mentioned earlier, and I'll go back here to find one. There we go. I think this is a good example. So I don't do the test myself, right? I have technicians do it. My technicians do it. I told you they love it. And if they love it, then I love it. And so that's why we're utilizing it a lot. And it's been very useful. But really what I'm looking at is to make sure that the strips, the sensor strips that you're seeing here are lined up correctly, to make sure that it's accurate. And, you know, when we first started utilizing it, my technicians were getting used to it. There were times where, you know, our strips were off a little bit, and that'll throw your measurement off. And so you can see these two strips lined up perfectly. As I mentioned earlier, you want it lined up directly with the pupil, this edge lined up directly with the pupil, and you're going to get a nice accurate measurement. So that's really what I utilize those images for, just to make sure that we have an accurate measurement.
Great. Thank you very much, Dr. Schweitzer. Another question is, how long does it take to do these tests approximately?
Boy, it varies a little bit by the type of test that you choose. I mean, some can be as short as a minute. Some can be a little bit longer, up to 3 minutes. It really depends on what test you particularly choose. And when we got the device, you know, we knew what we were going to utilize it for. And so, you know, LKC did a great job. They came in and they trained us on what to do. So it varies a little bit, so I can't give you a specific answer, but it does not take a long time at all. If you're using it for diabetic patients or glaucoma patients, it'll depend on the test, but trust me, it's not going to put a crunch in your workflow at all.
And actually, that kind of leads into the next question, which is kind of related. From a workflow standpoint, when do you do the test? Like in the lane and in the pretest room, how does it fit into your flow?
Yeah, great question. I mentioned this earlier, but I know that I probably went through it really quickly, so I apologize. Our patients don't leave their exam chairs. And I don't get this on every glaucoma patient. I'll be upfront and honest about that. But I utilize it on patients where I have, for example, an OCT that I can't get a good measurement on. So they have a lot of peripapillar atrophy, or they have a dense medial opacity where I can't get a good one, or a patient that can't take visual fields. I like to have this because it's another added piece to the puzzle. And so what I do is we just put a tech light on and I order it, and the technician comes in and they do it right there. So the patient never leaves the chair. There's no need to. It's a very small device, as you can tell, and they just take it off the docking station, come in, hook up the electrodes, and we're off to the races.
Perfect. Thank you, Dr. Schweitzer. That's it for questions so far. I'm sure there'll be more after the cases.
All right. This is my favorite part. I love cases. I'm a clinician. I'm in clinic every single day, and I'm sure a lot of you are as well. And that's kind of the fun part of utilizing technology. And so really, we're going to talk a lot about glaucoma on case 1 and 2. And so I'll get a little nerdy with some of the things that we'll talk about, and you'll see how ERG, and specifically the RETeval, really helped me and guided me in this situation. This was a patient, as you're going to see in a little bit, that had kind of funky optic nerve heads, and really the OCT is not useful, and it hadn't been useful. So I was never really able to get a good measurement of the optic nerve head. We didn't really know what the retinal nerve fiber layer was doing. The ganglion cell layers, you'll see here a little bit, was off as well. And then the pressures kind of threw me off a little bit as well. Good IOP reduction here, as you'll see, but still something that we had to address. So here's the patient, 67-year-old Caucasian male with a long-standing history of primary open angle glaucoma. He presented to me for a recheck just recently in August of 2021. And this is a patient that I'm managing with another optometrist in the community, and I do this a lot. Again, I'm in a tertiary care practice, so I work with optometrist colleagues, friends of mine, and we share patients back and forth. They ask me for another opinion, or they'll say, hey, can you give me an idea of what you think in this situation? And I'll take a look at them. So this is one of those particular patients. You can see the vision uncorrected was very good, and this patient did correct to 20/20 in both eyes. Ocular history, they've had cataract surgery, they have trabecular micro bypass stents, and had a YAG as well. They are medicated right now on a prostaglandin as well as a beta blocker. And then on the right there are all the intraocular pressure measurements. And I use an instrument called the Ocular Response Analyzer to take my pressure measurements. Plenty of data supporting this particular instrument. I do aplanate as well. But what you're seeing here is the most important measurement to me is this IOPCC. This patient's pressure was about 16 in the right eye, 17 in the left eye. The IOPG is the Goldman equivalent that you get with this particular instrument. And then corneal hysteresis is an important measurement for me as well. It's assessing risk. High corneal hysteresis, 10 or above, tells me that there's a less likely chance this patient's going to progress. 10 or below, I'm a little bit more guarded. A low corneal hysteresis situation would probably be 9 or below. We know from a lot of studies that low corneal hysteresis equals a risk for progression. And then we look here at the corneal thickness, 535 and 530. Now, this patient isn't ocular hypertensive, but if they were, this would be a high-risk patient if they were ocular hypertensive. We know that from the OAT study. And really the two numbers to keep in mind from the OAT study is patients with corneal thickness less than 555 are high risk. Patients with corneal thickness of 588 or above, or just 588 or, above 588 are lower risk if they have ocular hypertension. Okay, that's from the OAT study. In between 555 and 558, it's normal risk. So you have high, normal. So those numbers are really important. Keep those in mind for your ocular hypertensive patients. Below 555, high risk. Above 588, low risk. You can see the IOP max, which is an important number, 22 in the right, 23 in the left. Open to the ciliary body with no pigment. We got to do gonioscopy for managing glaucoma patients. And then when we look at the fundus photos here, the reason I put these up here, these are more of a wide field view. And so, normally we would zoom in or have a more up close picture of the optic nerve head when managing a glaucoma patient. But really what I wanted to show you here is two things. In the right eye, there's an epiretinal membrane. And I also wanted to show you here all the peripapillar atrophy and how hard it is to really judge the optic nerve heads on this particular patient. And I'll tell you, I had trouble judging it. I believe they're about a 0.60 and about a 0.65, but the peripapilar atrophy really threw me off. You'll see here in a little bit that it throws the OCT off as well, and it throws off the epiretinal membrane, throwing off the retinal ganglion cell, and that's what this is here. So I'm only showing you one of the OCTs. I have multiple OCTs on this patient, and the numbers vary all over the place. So when we look at the Tisnett curve, when we look at the values in the segmentation plot, they are all over the place on this patient from previous years, and it's because we just can't get an accurate OCT measurement because of all that peripapilar atrophy. And then the retinal ganglion cell layer, we have trouble getting that as well because the right eye, as you can tell right here, has an epiretinal membrane that's really affecting what we're measuring in the retinal ganglion cell layer. And so again, the OCT in this particular patient, really hard to make decisions also off of, really hard to decide what are we going to do in this particular situation. And then we look at the visual field, and I've kind of thrown up the last 4 or so that we've gotten on this patient, and really some variability. But if we look kind of in this area right here, right eye, so inferior nasal quadrant, there continues to be this little defect that shows up over and over again. And then maybe an early nasal step here dating back to August of 2020, February 2021, and then here in August of 2021. But it's really hard to match structure and function because I can't get a real accurate OCT. But I am concerned that this patient has glaucoma. We believe they do. They've already been diagnosed with it. The question is, are they progressing, and are they at risk for progression? And I can't really utilize the OCT to make that decision. When I look at the visual field here, the pattern standard deviation seems to be holding pretty steady. There's some variability, as you can tell here. The mean deviation as well, if we look at that, holding pretty steady around 4 to 4.5 since 2019. So my gut suspicion is this patient is probably stable. And then we look at the left eye, definitely a glaucomatous defect. I'm giving you about 6 different measurements here, but we have this inferior arcuate defect. Okay, we have a nasal step there, but again, looks fairly stable to me over the years. The pattern standard deviation not changing a lot. The mean deviation holding pretty steady as well. But again, no structure and function test that I can really pair the two together because the OCT technology is just not accurate. So this is where ERG really painted a nice picture for me, because when we look at this particular printout, we know there's damage. So when we look at the amplitude, it's showing that there's damage to the cells. We know that. We believe this patient already has glaucoma, okay? The W ratio being below 1, not a surprise. We know there's damage to the eye. We know there's damage because we have a visual field defect. This patient likely has glaucoma. But what really helps me out in this case is looking at that implicit time. You can see it's within normal limits at about 44% in the right eye, at about 69% in the left eye. This makes me confident that this patient is stable. It's fitting the clinical picture that I believe. I'm looking at the visual fields. They look pretty stable, but I want to be more confident. Patient has a high corneal hysteresis. Pressure is pretty well controlled. Remember, the Tmax was 22, pressure is around 17. So the ERG is really managing the clinical picture that the remaining cells that this patient has, the remaining retinal ganglion cell that this patient has, is not being stressed at this point in time. And I'm going to continue to monitor this patient on a pretty consistent basis. This particular patient I've been seeing back every 6 months, and I'll continue to do that. I feel comfortable with that because the clinical picture is saying it's a pretty well-controlled situation. We'll keep monitoring that patient. Andy, any questions on that? Did anything pop up? I can pause just for a second.
Sure. Yeah. So Dr. Schweitzer, it's more kind of billing related. They noticed that you did an OCT, fundus photographs, visual fields. Can you bill a full field ERG on the same day as OCT, fundus photos, and visual fields?
Yeah, no, and so I don't bill fundus photos either on the same day that OCT, and a lot of you know that already, so we don't, and I don't bill the ERG. And I'll be honest, really for the ERG and glaucoma, I'm only billing it for ocular hypertensive patients and glaucoma suspects. But I find the tool so valuable that I'm willing to go ahead and do this test on a patient like this and get the data because it's helping me feel more comfortable and more confident. So it's a great question, but it would be for ocular hypertensive and glaucoma suspects where you would bill it.
Okay, thank you.
You bet. All right, so case number 2. So this is a patient that came in. You're going to see here a new patient referred in to me because they had cataracts and questionable glaucoma. The doctor wasn't sure. They were questioning, does this patient need treatment? Does this patient need to go under a MIGS procedure? Now, what should we do for this particular patient? And so this was a glaucoma suspect type of patient. So 69-year-old Caucasian female. The referring optometrist had labeled this patient as a glaucoma suspect. It's been getting harder to see out of her glasses is what she said. And she's noticing more glare at night. A lot of information here, I know, but you can see the visual acuity uncorrected about 20/80, 20/70. Best corrected acuity, not getting a ton better than that. Stayed really about the same. So I wasn't really able to improve her visual acuity. You can see it got to about 20/40, but she batted down to about 2400. Glaucoma suspect, as I said, that was already labeled by the referring optometrist, not on any medications, and no medical or drug allergies at this point in time. When we look at the slit lamp, some mild epithelial basement membrane dystrophy, and then a pretty dense cataract, 2+ to 3 opalescent cataract. So it's hard for me to even get a view in the back of the eye. You can see the intraocular pressure here. That IOPCC, the one that I really care about, at 18 in the right, 18 in the left, and then a high corneal hysteresis as well in this particular patient. Central corneal thickness being 540, so that would fall in that higher risk situation if we think of the Oates study. Gonioscopy, open the ciliary body, and then we'll look at some additional testing here in a little bit. My best assessment of the optic nerve head was about 0.5 in both eyes with the normal macula. Again, hard to assess it because of the dense cataracts, but I was able to get a decent view of that. So here was the OCT. And really everything's looking pretty normal here. Accurate OCT. Yeah, the cataract may mess with it a little bit, but we got a pretty accurate OCT here. We look at the different layers here. The retinal ganglion cell layer right over here, looking very normal, looking robust. We look here, the retinal nerve fiber layer segmentation plot. And even if you look at the Tisnet curve, pretty healthy looking retinal nerve fiber layer here. So it makes me feel good about where we're at there. But then you look at the visual field. And so this was a little bit concerning. Left eye on the left side over there, right eye on your guys' right side. And a couple of things jumped out at me at this. Number one, it kind of looks like a nasal step in the right eye. It definitely has that appearance of a nasal step in the left eye with arcuate scotomas. The other thing that worries me a little bit here is, could this be something neurological? Because when we look at it, you have this, quadranopsia that kind of fits in. Could it be something at the level of the chiasm? So that was in the back of my mind as well. Now, when we look at the OCT being so normal, that's why I was thinking, could it be something neurological, or could it just be the cataract because it's such a dense medial opacity that's creating some of the visual field issue that we see here? And so I don't rush a patient like this off to get an MRI right away. I will educate the patient that it could be a couple different things and that we should really assess this. We know we got to get the cataracts out. We'll probably and very likely repeat the visual field afterwards, which we did. But this was a patient where I wanted to get an ERG because it could be beneficial in kind of giving me more confidence in how I'm going to educate the patient. And so again, when you look at this right eye, left eye, we drop down to this photopic negative response, the area we care about. You can see the implicit time being really good, so no stress on those cells. We can see the amplitude is excellent, and we can see that W ratio being right around 1. In the left eye, same situation. The implicit time being very good, the amplitude being really good, and the W ratio being just shy of 1 at 0.99. So I'm comfortable with that as well. Again, making me confident that, number one, I doubt this patient has glaucoma. I highly doubt it based on the clinical picture that we looked at. Think about the risk that we looked at. We have a patient that has fairly decent eye pressures at around 18, a high corneal hysteresis. Yes, they have thinner corneas. The OCT looks pristine. We have an ERG that looks completely normal. The only thing that's throwing us off is that visual field. And so really what happened in this particular patient is we took the cataracts out. We ended up repeating the visual field, and all the defects you saw went away. The patient's visual field actually tested out normal. So it could have been user error by the patient just getting used to the test at the beginning, or it was the medial opacity, which is what I believe it was. It was the medial opacity. And so this patient underwent cataract surgery, is back with the referring optometrist and doing great. So again, building confidence in what you should do or analyzing what you should do for a patient. So Andy, I'll pause there again. Any questions about that case at all that popped up?
Actually, there's not a question with regards to the case, but one of the doctors online just wanted to chime in and say that there is a separate procedure code for full field ERG, so you can bill this to insurance on the same day with a medical diagnosis. So I guess this is an existing RETeval owner that wanted to let us know that. So sometimes the questions are a little bit delayed in terms of the case, so I'll keep an eye out and see if more come in.
I appreciate it. Yeah, I mean, you know this, Andy. I've been just I've been so thrilled with it that I'm personally, you know, less concerned about billing. And I know we're all in a business world and we need to bill for things and we want to get paid for things. But you know, I just feel like the benefit that's provided me, you know, the billing to me is secondary at this point, where I'm at with the testing that I do. That may not be what everyone feels out there, and I don't know if that's necessarily the right answer, but it's really worked for me, and it just goes to a testament of how I've enjoyed and love having the technology in my practice.
Great, thank you.
All right, so let's look at a couple other cases here, and then I'll be done and just take a few questions if anyone has any. So these are a little shorter cases, but this gets into kind of the diabetic area, you know, the diabetic retinopathy, and where can ERG kind of help us in those situations. And so this is not my case, but one of our colleagues' cases, and this was a 46-year-old patient, type 2 diabetes for 5 years, hypertension for 5 years, metformin. You can see what the A1C was at 6.8. Some fundus photos here to look at. And when I look at that, I looked hard, but I didn't see any diabetic retinopathy anywhere. And correct me if I'm wrong, but I looked hard to find something and I really could not find anything. And again, not my case. So that's why I looked hard to see if I was missing anything. So looks like a pretty healthy retina to me. And then here's what the ERG came out as. And so just really confirming the confidence we have that this patient is doing well, this patient is well controlled. And you can see here that a 12.5. And remember, in review, that magic number 23.4, so above 23.4 would put that outside of normal limits. And this patient being at 12.5 puts us within normal limits. We have good implicit times, we had good amplitude here, good pupillary response. So we get a good DR score, and we can educate this patient and say, hey, I probably don't need to see you for another year, where we'll do your comprehensive eye evaluation. We'll take a really good look in the back of your eye, but you need to continue to control your diabetes. Another case here. So this is where ERG comes in. This is another diabetic situation. So this was a 53-year-old white male, type 1 diabetes for 20 years, high cholesterol for 3, and some mild non-proliferative diabetic retinopathy for about 5 years. The last A1C was about 6.9, and best corrected visual acuity 20/20 in both eyes. When we look at the fundus photos here, there is some diabetic retinopathy showing up, and that was mentioned here in the history, and this patient has had it for quite some time. This obviously raises a little bit of a red flag, makes me a little bit more nervous. We're going to examine this patient a little bit more closely, going to talk to them a little bit more about control, and then also what you're seeing here is what's going on with the OCT or the macula. And I would say when you look at this, the left eye from baseline to follow-up looking pretty similar. You look at baseline in the right eye to follow-up, and maybe just a little bit of fluid in that macular area in that right eye. And so raising a red flag of how concerned should we be? We get an ERG. You can see that DR score at 22.1. Remember that magic number of 23.4. If it's above that, there's that increased risk. And here, falling within that normal limits. So what does this tell us? Does this tell us, boy, we don't need to see this patient for a year? No, probably not. It's telling us we can feel pretty confident that we can monitor this patient closely. Maybe we bring them back in 3 months or 6 months and repeat that macular OCT to see if there's been any changes done. That number is approaching that 23.4, but I'm not going to intervene. I'm definitely not going to make a referral to a retinal specialist. I'm going to keep this patient in-house and manage their diabetes, because with the ERG, it just makes me more confident. So with that in summary, we're finishing up right on time. I mean, when we think about this, this is a tool that can be utilized in our practices. And I think, you know, for me, it's been a really welcome tool for my glaucoma patients. It's been a really welcome tool for my technicians. They love utilizing it. It's easy to utilize. Patients like it. They don't have to move. The biggest thing for me is confidence. I've mentioned that many, many times. It really helps me feel comfortable with some of my clinical decisions. When things are a little muddy, I like to go to this. I like to have it. I like to have it as part of my glaucoma puzzle piece. And that's really been where it's been very, very successful for me. I don't get it on every patient, but I do utilize it in certain situations. So we talked a little bit about this. There is a code for this. This has been brought up a few different times. You can see average Medicare fee. I talked a little bit about billing earlier. So this is ERG with interpretation in full field. It can be utilized again in diabetics. As mentioned a little bit ago, it can be utilized in glaucoma suspects, ocular hypertensives, and the full field as well in glaucoma patients, as mentioned by that doctor that was on here earlier. All right, so Andy, I think we're right at that kind of time where we left a few minutes for any questions. Otherwise, I'm happy to give time back to everyone, but I do appreciate everyone taking some time tonight. I know, again, it's never easy to do, and means a lot to me for the questions you have and just being here with me tonight.
So, Dr. Schweitzer, there was just a couple more questions. So, I guess one of the questions was, how long did it take you to get comfortable with the interpretation of the results, with the reports?
Yeah, that's a great question. So, really, Andy's on here, and he initially helped me and trained me on how to utilize it. And it did take me a few tests. I would say it probably took me about a half a dozen tests. It took me emailing some of the LKC team to just make sure I was interpreting them correctly. But after I got through those half a dozen and I felt comfortable with what implicit time meant, what the amplitude meant, what the W ratio meant, knew exactly what I was looking for, it was no problem at all. So for me, it took me about a half a dozen. For some of you, you're probably smarter than me. It'll take you 2 or 3 times, but it took me about a half a dozen times.
All right, thank you. And Dr. Schweitzer, I did have a question from earlier in the presentation. Does the pupil size matter when you're doing the tests?
No, great question. No, it really doesn't matter. It can be any size pupil. So you may have the patient, you may want it before they're dilated, you may want it after. So it does not matter. It can be done in a non-miniaturizatic situation as well.
Excellent, excellent. I think that's it. Oh, wait, actually, I think one more question came in through the email. Let me just double check. All right, no, I think that's it. So, hey, thank you very much, Dr. Schweitzer. I really appreciate your time today, and thank you everybody else for attending. If you have any questions, please feel free to reach out to myself. I can always pass them on to Dr. Schweitzer, and my email address is ajones@lkc.com. So once again, thank you very much, Dr. Schweitzer. Thank you very much to everybody who attended. I hope you all have a pleasant evening, and everybody take care. Thank you.
Thank you.